Hello, everybody. Welcome to today's webinar where we're going to be discussing community psychiatric support and treatment for youth. My name is Lisa Job Shields. I'm the Behavioral Health Division Director at Virginia Medicaid, and I'll be one of the presenters today.
Hi, everybody. My name is Carrie Savage. I'm the Director for the Office of Child and Family Services at DBHDS.
Hello, I'm Catherine Hunter. I am the Child and Family Behavioral Health Program Manager in the Office of Child and Family Services at DBHDS.
And I'm Karen Grabowski, also with the Office of Child and Family Services at DBHDS.
Thanks, everybody. You can go to the next slide. So what we're going to talk about today, again, is Community Psychiatric Support and Treatment, or CPST for Youth, which is one of the redesigned Medicaid behavioral health rehabilitative services. We're going to do an overview of the service in general. We're going to do an update on the statewide training plan. We'll be doing 3 case examples. Next slide. First, I just want to give a couple disclaimers. The purpose of this information is to share the details of the draft CPST policy in a second format and with examples. All of the policies that we're going to describe here are currently in draft, and they were posted for informal public comment. They are subject to change. You can find these policies on our website, even though the informal public comment period has closed. You can still submit comments to us via our enhanced BH inbox. And the final policy manuals will be posted at a future date, and they would go into effect July 1, 2026. Next slide. I also want to note that this webinar is not meant to be a training in how to deliver CPST. And this information will include information about what the statewide training is going to look like. So training will be much more in depth, but hopefully this will give you a general sense of what the service components are and a lot of the details about how the service will work and look in the community. Next slide. So first, just some basics. CPST for Youth will have one DBHDS license, and it will be called CPST Youth. There will be 2 separate DMAS policy manual sections, one which will be referred to as CPST Community, which is what we're going to be talking about today, and then one that is called CPST School Setting. There are a lot of similarities, but ultimately we decided to have 2 separate policy sections. You can find the drafts on our website, but again, today we're going to be talking about CPST Community. But in general, the CPST Youth license overall is going to replace both intensive in-home services and therapeutic day treatment as of July 1st, 2026. The new CPST rate will be billed at a 15-minute interval, and the rates are based on the professional type. You can find more information about the rates on our website.
CPST has 3 prongs or 3 pieces of it that are very important. We're going to briefly go over what those 3 pieces are. If you can go to the next slide, please, Karen. CPST is a multi-component service, meaning that it includes assessment, treatment planning, crisis support, care coordination, skill building, and counseling. You will see that the comprehensive assessment of needs plus a diagnostic interview is what is going to drive the treatment planning, which absolutely should be person-centered. The treatment plans, including the person-centered clinically indicated combination of the pieces below, psychotherapy, crisis support, rehabilitative skills training, and care coordination. And then the youth that are approved for Tier 2 services, which I will talk about in just a minute, also may receive repetition or practice of the skills being developed. The goal here being that youth really get the opportunity to practice the skills that they're being taught in the settings in which they would need those skills. Next slide, please. All right, there are 2 tiers of service intensity, and both tiers are rehabilitative, and they should demonstrate more comprehensive services than outpatient therapy. The way that this will be demonstrated is by working with young people in their community or at home based on their need or where their symptoms are manifesting. And then also supporting the entire family, so that we're looking at this very holistically, so that the youth and their family unit, however that unit is comprised, is receiving the support and education that they would need in order to build on their strengths with their identified service provider. So Tier 1, young people will receive between 3 and 8.7 hours of service per month. Tier 2, they will receive between 9 and 28 hours per month. And it is important to note that Tiers 1 and 2 have different medical necessity criteria.
All right, so first I want to talk about medical necessity criteria for Tier 1 CPST. So first, there's the diagnostic criteria. You need a primary ICD or DSM diagnosis or a provisional diagnosis. So this is a change from most of our current services, where we will be allowing for the first time for a provisional diagnosis to be used to get someone in the door for this Tier 1 service. As far as functional impairment, there needs to be evidence of moderate impairment of functioning, and the areas where that could be demonstrated are managing the symptoms of the mental health disorder, social relationships or community integration, personal care, daily living skills, or personal safety and self-regulation. So in addition to the diagnosis and the functional impairment criteria, there's also what we are calling service intensity criteria. So like Carrie said, both Tier 1 and Tier 2 services are more comprehensive than outpatient therapy. And so to look at that service intensity criteria, essentially there needs to be evidence that they need this weekly intervention, at least weekly, and the focus needs to be on skill building and community integration. It'll be between 4 and 6 hours a month, or up to 8 really in the full range. And also you need to show that there is a need for these behavioral interventions to be done in the real environment, with environmental modification, real-time coaching, and things like that that make it, again, more comprehensive than outpatient therapy. Next slide. Now, the Tier 2 medical necessity criteria are going to look a little bit more similar to how you might think about the criteria for some of our current rehab services. We have definitely updated all of the language, but it is a higher bar, a higher threshold of functional impairment, and a higher need for more intensive services to get Tier 2 services authorized. So number one, there does need to be a primary ICD or DSM diagnosis, and it needs to meet criteria for early serious mental illness, or serious emotional disturbance. As far as functional impairment, there needs to be evidence of significant functional impairment. It's in those same areas: symptom management, social relationships, community integration, personal care, daily living skills, personal safety, and self-regulation. And then you can see that there is there's a higher level of service intensity needed. So there is still that focus on skill building and community integration, but it also has a focus on crisis support, and has the hours of between 7 and 28 hours per calendar month. So it's more hours, more of a integration of crisis supports, more need for care coordination with multiple service providers, and things like that. Next slide. So I want to talk a little bit more about the service intensity and how CPST compares to outpatient therapy, as well as services that are more intensive. So, if you look at the literature regarding mental health conditions and the recommended treatments and evidence-based practices, for a lot of mental health problems, outpatient therapy and medication management are the first line treatments. So thinking of youth conditions such as attention deficit hyperactivity disorder, major depressive disorder, a range of anxiety disorders, essentially there's specific symptoms and functional impairment, which qualify for someone for a mental health diagnosis. And again, a lot of the times what you'll see for a first line recommendation is therapy and med management. Now, youth are going to be referred to CPST instead of outpatient therapy and med management if, in addition to having the diagnosis and that functional impairment, There's a need for a more intensive service, a more comprehensive service that's going to have that real-world skill building, care coordination, and crisis supports for the individual. So, one theme that you're going to hear, and you'll hear it a lot as we go into the case examples, being eligible for CPST and being recommended and referred to CPST versus outpatient therapy and med management, it doesn't change, the model of change or what's known about the evidence-based treatment for a mental health diagnosis. It just provides more intensive supports, more integrated, more real-world supports to achieve the same goals. Next slide.
So you've heard Lisa and I both talk about how CPST is more comprehensive than outpatient therapy and medication management. However, there remains multiple other community-based services that could also meet the needs of a young person when indicated based on their assessment and the outcome of that assessment. So some of the services that you can see on the right-hand side in the red squares that are evidence-based, that might be more appropriate in treating the symptoms that youth might be demonstrating than CPST. So we would need to make sure that when we are referring to these services, that the eligibility is taken into consideration as well as the client and family preference. We really want to make sure that we are focused on person-centered planning and involving the individual and their caregivers in the decision-making process.
So this chart just shows, again, kind of both of those sides of the coin together, treatment intensity that is less intense and more intense, or the same amount of intense that as CPST. So this essentially shows a range of the treatments in our continuum in Medicaid, the average weekly and monthly intensity, and any other details about it. Because our goal here is to have a continuum of supports that meet people with the least restrictive services, in the community to meet their needs. So this is just kind of, you can see in the blue there is tier 1 and tier 2 CPST and how it compares. So less intense, we have that outpatient therapy, which, although you can do weekly therapy, which would be getting, close to at least the level of timing of tier 1 CPST, oftentimes people are going, every other week or something like that. Our average intensity is 1.6 hours per month, and it's typically clinic-based. So again, you can see tier 1 CPST is just one step above that. Based on the different levels of need. It's going to be somewhere probably between the 3 and 8 hours per month. And then right above that is what we know as some of our more intensive evidence-based practices that stand alone in our Medicaid benefit, like functional family therapy. So that is typically 8 to 10 hours per month. And then higher than that, we have multisystemic therapy, which is often 16 to 24 hours per month. Kind of right in that range, maybe and going a little bit higher will be the new tier 2 CPST service. Now, again, all of these numbers are subject to change, and we've actually gotten a lot of feedback about having maybe single numbers versus these ranges as we move into the final policy. But as you can see, looking at it in general, we're going to be looking at 20 to 28 hours per month. Which is, kind of right in there with multisystemic therapy. Now, assertive community treatment, in some ways, we do want tier 2 CPST to meet the needs of people that maybe don't qualify for assertive community treatment, but do need that same level of support. And you can see that a base fidelity assertive community treatment team does 3.3 to 5.6 hours per month and sees members 5 to 8 times a month. And high fidelity does more. They actually do at least 8 hours per month and see the individual 12 times per month. So again, we want tier 2 CPST to be getting up to that level of intensity, but it's probably not going to be quite as intense. Now, even more intensive than those are our intensive clinic-based supports. So first we have intensive outpatient or IOP. That is 6 to 19 hours per week or 24 to 76 hours per month. And also our partial hospitalization program. So that's at least 20 hours a week, so around 80 hours per month. So again, these are more intensive services, really high number of hours. That's going to be more than the tier 1 and tier 2 CPST supports. Next slide.
All right, let's talk about that third component to CPST, which is that it is a collaborative behavioral health service. If we look at the next slide, we see the definition of a collaborative behavioral health service. Long story short, this is a team approach and should always remain a team approach, regardless of how many professionals the young person is engaged with. So if we can go to the next slide. We see that CPST policy sets a minimum standard for supervision activities, inclusive of supervisor to staff ratios and clinical direction for all CPST providers, so that we can make sure that the service is as collaborative and team-based as possible. How the team is functioning, as well as what that structure looks like and who interacts with the young person, is really going to depend on the credential level of the provider and the level of tier of service that Lisa talked about earlier that's being provided. Even though a team may only consist of an LMHP and a QMHP, and the young person is only seeing face-to-face one of those people, the concept of the collaborative behavioral health service should remain fully intact. So there should always be a collaborative team-based approach in service provision through the CPST model.
So these are just two high-level examples of what that collaborative behavioral health approach would look like. Later in the presentation, you're going to get three different case examples, but this is just sort of a high-level view of what does it mean to have these different members being part of a team serving an individual. And family. So for one example would be if the youth presents with oppositional or disruptive behavior, we know that the evidence-based intervention would be parent management training in some situations. So in this situation, you can see the LMHP would be doing the assessment, maybe selecting the specific approach, maybe doing some of the initial work with the family, and really just carrying general oversight of the treatment plan. Whereas the QMHP would actually be out there in the home, delivering the psychoeducation, practicing the skills, doing the timeouts, doing special time, making sure that there's a crisis plan in place, doing the care coordination. And then if there was, if they were getting tier 2 services, there could also be a behavioral health tech involved, or the QMHP could be providing more hours, where essentially you're just practicing more and more, using those hours to practice the skills, reinforce any type of tools such as tracking that are being used, and things like that. You can see same thing, for example, a traumatic stress symptom presentation. The LMHP will have specific pieces related to assessment and some of the more psychotherapeutic components that would be needed. Whereas then the QMHP could be doing training on, how to do relaxation, different paradigms, dealing with emotions, maybe cognitive coping, again, that crisis plan, and all of that. And same thing, if there's a behavioral health tech involved, they would be doing just, essentially practicing those same components but with more time and more hours. Next slide. So thinking about kind of these teams, thinking about tier one services, there's really two ways this could look. There's two types where the family would only meet face-to-face with a single staff person. And then there's some where the member might meet face-to-face with two people. So first, team types 1 and 2, if there was a licensed supervisor and then an LMHP or type 2, an LMHP in training, it would only be that LMHP in training that would actually go out and see the member, meet with the family face-to-face, and the licensed supervisor would be, providing supervision in the background. On the other hand, team types 3 and 4, if there is a QMHP that is doing that direct care, the licensed supervisor would be seeing the family and the member at least every 90 days. So kind of again, depending on who is a member of the team. At tier 1, there could be either 1 or 2 people that would ultimately be doing some face-to-face work with the family. And again, if it is a team type 3 or 4, they would need to be seeing the L type at least every 90 days. Next slide. So this is just a high-level example of what a month could look like of that team type 3 or 4. So this is a kind of a mid-level example, 5 hours, so kind of more on the low end of what would be allowable under Tier 1. And a total of 20 units billed. So again, as you can see, it's mainly weekly contact. You can see that at the month it starts off with a 60-minute session with the LMHP where they're actually kind of finishing up the assessment, maybe starting to explain the treatment plan and things like that. But then right after that would be the first session with the QMHP where they're out in the home, setting up whatever tracking needs to happen, working on the crisis plan, rehearsing any of the things that they've already kind of set as goals in the treatment plan. You can see in this section, in this example, there was a crisis support via the phone that was billed just that next week. And this will be a theme as throughout the presentation. For Tier 1, again, it's only about 5 to 8 hours a month. As you know, that's not going to be enough. That's not going to be enough for there to be a lot of crisis support, right? If someone is experiencing a lot of crises, like on, multiple times a week or even once a week, that they're going to meet criteria for Tier 2. But at Tier 1, people sometimes are going to have crises and ultimately might, in this example, stay at Tier 1, even though they are, that's why crisis is part of the service. But again, so, there was that crisis support on a Monday, but then they followed up 2 days later, had that actual session in the home, again, about 60 minutes of just doing the tracking, the crisis plan, rehearsing. And you can see in these empty days where they're not seeing someone directly, again, it really is that outpatient behavior change model of, you're guiding yourself through practice. If you decide on Thursday that you're going to track a certain behavior each day, you'd be doing that in the interim. And then you can see, again, sessions followed out just once a week in this example for a month. And again, this is kind of a mid-range example, only 20 units were billed. But just wanted to show kind of a sample month for Tier 1. You can go to the next slide. All right, and so this is getting into the Tier 2 team types. Now, theoretically, Tier 1 teams could also deliver Tier 2 services, but it wouldn't really make sense because, essentially it would be a kind of a licensed person or a license eligible person billing for something at a rate that, is really more so for the behavioral health tech. So it's probably unlikely, again, it would be allowable, but it probably wouldn't be used very often. And so most of the time with the Tier 2 teams, the family will be interacting with at least 2 staff members. Now, and there's one where they could even be seeing 3 staff members. Most of the time, it's going to be two staff members. So you can see it could be a licensed supervisor and a QMHP, where the QMHP is doing all of the direct direct service hours outside of, every 90 days, something to that extent. It could also be an LMHPE plus a QMHP that see them, and then the licensed supervisor is more in the background, and the LMHPE is the one that is the second person face-to-face, for example, at least every 90 days. And you can see all the examples like that, essentially, even whether it's a licensed eligible person or QMHP that's doing most of those treatment components, there's always going to be a second person involved, either on the license end every 90 days or someone like a behavioral health tech that's doing the repetition pieces. Then again, there is one team type, we would call that team type 7, where there would be 3 different people interacting with the youth and family. And what that would mean would be that, at least every 90 days, they're seeing the licensed person. And then the QMHP is going out and doing all of the skill building, care coordination, crisis supports, a lot of that time. And then a behavioral health tech is also going and practicing with the person. So say if there was, a pretty intensive skill and it just, needed practice multiple times a week, it would be, introducing the family to someone else who could come out and practice those skills with them. So again, there could be times where they would be having some face-to-face contact with up to 3 people, but typically with Tier 2, it's going to be 2 people. Next slide. So this is just same thing as the other one. It's a sample month of a tier 2 schedule. So, you know, you're going to see essentially the main difference between this and the tier 1 is just the number of units billed. So this is, again, kind of a moderate one. It's just 21 hours. Tier 2 can go up to 28 hours a month. But in this situation, they are you can see that there's crisis calls. So for example, look at that on Friday the 6th, a crisis call came in, and actually the QMHP had to go out in person. So right on the tier 1, it was a phone call, is much shorter. This is 105 minutes of in-person crisis support. So, you know, demonstrating that higher level of need. And then, you know, just 2 days later, going back and doing a 120-minute session of, you know, just, you know, practicing the skills, reinforcing the crisis plan and all of that. And as you can see at tier 2, now it doesn't have to be like this. It really obviously depends on the needs of the client, where they live and all of that. But in this example, they're actually getting engagement 3 times a week. And again, you can see that they're seeing a QMHP and a behavioral health tech throughout the month. There's those crisis calls that will come up when they happen, and you know, just a much higher level of engagement, many more units being billed for tier 2. Next slide. All right. So I wanted to show just an example of what this could look like for an individual staff member, right? So the other 2 calendars showed the what it would be like for the client schedule. This would be what would it look like for the staff member. So as you can see, if someone were to have a blended caseload, in this example, it's a pretty realistic example. Someone would have 3 tier 2 clients and 5 tier 1 clients. And as you can see, many days they're seeing 3 clients, never more than 3 unless some of them are virtual. One thing that we do want to point out is that there's a lot of the components can be done virtual, face-to-face. So that's definitely something to take into consideration when looking at the schedules. You can see the care coordination meetings in there throughout, and essentially this is just, you know, one example of what it would look like to be carrying a blended caseload of 12 and a half. This example has 453 units billed in the calendar month. And one thing I want to point out is, you know, in our policy, we're setting caps on the caseload and caps on the units billed. Those are very high numbers in our opinion. Again, those are that's just as high. You know, if there were extenuating circumstances or, you know, for a number of different reasons, it could go that high, and we wouldn't, you know, we would still consider it CPST and all that, but those certainly are not the numbers that we recommend. Again, so for example, the caseload limit is 20. This example here that we think is very good and fits in with the rate study and what was assumed about like how many people they would see a day. This comes to a blended caseload of 12 and a half. So again, it's those maxes that you'll see in the policy. That is not the recommended caseload. That is just the ultimate max. Go ahead. All right. And similarly, this is just a little bit more information to wrap up that line of thought, just some different ways that a full-time QMHP's caseload could be structured. So in addition to the example that we just did, here this could be, you could have, for example, 8 tier 1 clients and 3 tier 2 clients. That would be if the QMHP was doing all of the direct work, not working with a behavioral health tech, but doing all of the hours individually. Another example would be 5 tier 1 clients and 6 tier 2 clients. But in that situation, it's a lot of clients, but there would be a tech working on all of those cases. So doing a lot of the hours and a lot of the practice there would be another staff person involved. Another simple example with the limit of 20 as the case limit, someone could just have 20 tier 1 clients, for example. And then another example on the other end would be having 7 tier 2 clients. We said, you know, for example, you could have 4 where you're billing about 60 units a month working with the tech, and then doing 85 units for 3 of the clients. So again, if this was carrying a really intensive caseload, 7 clients total, working with a tech on some, but not all. And so the reason we give these examples are because they meet the productivity assumptions of the rate study. They also meet the caseload limits, the unit build limits, and all of that. So just wanted to kind of demonstrate what it could look like, and again, that those maxes that we use are not the recommended, and they're not what was assumed by the rate study. They're just the max limit there.
Lisa, grab some water. That was a that was a run. All right, so hopefully everybody now has a better understanding of these three facets or pieces of what CPST is. So remember that it is a multi-component service. There are 2 tiers of service intensity, and that it should always remain a collaborative behavioral health service model. All right, now we are going to shift into training requirements. On this slide, you can see each license type or profession type listed in the red squares at the very top. And then underneath that, the correlating training that will be required. And we can just go through it very quickly because we're going to break it out a little bit more on the following slides. So licensed clinical supervisors who are not providing direct services must have the MAP direct services curriculum, which is a total of 40 hours of training. LMHPs and LMHP RS and RP who are providing direct services must have the foundational skills curriculum, which you will also see referenced as the FSC, 10 hours total of that, and the MAP direct services curriculum, consultation, and portfolio review in order to earn the MAP therapist credential. QMHPs and QMHPEs must have that foundational skills curriculum or FSC, and CPST Q/B, which stands for QMHP or BHT, curriculum for 10 hours. BHTs must participate in the DBHDS Behavioral Health Tech Academy, and where the FSC or foundational skills curriculum will be reviewed to see where there might be some overlap. So there might be some wiggle room on that. We'll let you guys know. And then also the CPST QB curriculum for 10 hours. Next slide, please. All right, so when I was talking about that FSC or foundational skills curriculum, which is that total 10 hours, the skills that we will be teaching in those trainings are motivational interviewing, crisis management, listening and engagement skills, person-centered planning, professional ethics, MAP basics, and the fundamentals of SED. And for the CPST QB curriculum, the tracks that we will provide or propose, or sorry, not provide or propose, the tracks that we will have available will be for anxiety, mood disorders, co-occurring substance use disorders, hyperactive and disruptive behaviors for youth ages 0 to 11, hyperactive and disruptive behaviors for youth ages 12 and older, and traumatic stress.
So we are really excited that the MAP training has kicked off recently. So just want to highlight just a few things about the training and the model in general. Really, there's 2 parts that are probably most unique, and one of those is the practice guide. So that's what we have displayed here. The other one is the dashboards. And so again, as we open up more MAP trainings and get everybody trained up on the model, you will be learning a ton more on this. But just wanted to kind of give a little bit of a glimpse to it, specifically on the practice guides. So practice guides are a critical component of MAP. Essentially, you will use these throughout whenever you're doing this service. This slide just has 2 examples, and essentially what they are is they are guides that are specific to like parents and caregiving. So the example on the left is attending, right? So you've probably worked many times with families and trying to train parents to be able to show positive attention to the child, and essentially all the important aspects that come to using attention to improve the caregiver-child relationship. So essentially, it's kind of like a cheat sheet in some ways. It has all the steps there, and it's something that you can use, again, whenever you're doing a session where you're training a parent on that skill. You could bring the practice guide with you, review it beforehand, and all of that. The example on the right is just an example of one you would use directly with a child. This one is about, it's a cognitive approach to trauma. So essentially, if a child is struggling with, some sort of distorted or unhelpful thought related to their traumatic stress, this again is just kind of that cheat sheet or that practice guide in terms of how you would go about doing that cognitive intervention for the trauma. So again, just some examples. When you do the training, you'll essentially for each problem area you'll be becoming proficient in lots of these practice guides. But just wanted to kind of give a little bit of a view into what they actually look like. Next slide.
Thanks, Lisa and Carrie. On these next few slides, we will outline the training outcomes for different professional types. And up first are licensed, eligible, and supervisors. Licensed and licensed eligible clinicians and supervisors will demonstrate competence to diagnose mental health conditions, including complex presentations, assign level of need based on statewide framework using the CANs, refer to standalone evidence-based programs such as MST or FFT when youth are eligible, connect diagnoses, strengths, and needs to an evidence-based treatment plan through a person-centered treatment planning process for emotional, behavioral, and traumatic stress-related difficulties for youth, communicate diagnoses, plans, and expected outcomes to youth and families directly, provide psychotherapy when needed, including using the MAP practice guides, coordinate integrated support provided by other staff through collaborative behavioral health service delivery model, including training and directing staff to use MAP practice guides, and finally, to monitor treatment progress through the MAP dashboard and direct changes to treatment plan as needed with a goal of rehabilitation and recovery. Next slide, please. Up next are the training outcomes for QMHPs or qualified mental health professionals. They will be able to demonstrate competence to conduct components of the CANS assessment, but not the diagnostic components, understand person-centered treatment planning process, engage in active listening and motivational interviewing to support youth and parents struggling with emotional and behavioral difficulties, develop crisis prevention plans and provide crisis supports, coordinate care across multiple providers, build skills with youth, caregivers, and teachers as directed by the supervisor, including the use of MAP practice guides and other evidence-based interventions. Communicate to other clinicians and supervisors on your team about the youth and family progress, including any successes and barriers. And finally, be able to participate in conversations with the team to consider changes to treatment plans as needed. Next slide, please. And finally, we will review the training outcomes for behavioral health technicians or BHTs. They will be able to demonstrate competence to understand person-centered treatment planning process, engage in active listening and motivational interviewing to support youth and parents, understand crisis prevention plans and skill building plans and the skills that are being developed, support youth and families in real time to practice the skills they have developed to manage crisis and build skills, including the use of MAP practice guides, and finally, communicate to other clinicians and supervisors on your team about youth and family progress, including any successes and barriers.
All right. So now that we have all of the information about what CPST is, we're going to go ahead and look at 3 specific examples to just talk about how this approach might be helpful or useful if you are possibly working with a 7-year-old with ADHD and co-occurring ODD, a 10-year-old with traumatic stress, and a 14-year-old with anxiety and depression. So our first example, again, that 7-year-old with co-occurring ADHD and oppositional defiant disorder. Evidence-based would say our first line of intervention is outpatient therapy and medication management, where psychotherapy is focusing on parent management training. But we know that with our new CPST services, if there is, in addition to the diagnosis and functional impairment, a demonstrated need for a more comprehensive service, which includes real-world skill building, care coordination, and crisis supports, then that referral may be necessary. And that it doesn't change the model of change or evidence base for mental health diagnoses. It simply provides more supports to achieve those same goals. So with this standard outpatient treatment, what you would be looking at is several appointments with a therapist, parents learning about positive communication skills, some appropriate discipline, maybe reinforcement of prosocial behaviors and structure environments. Some practice would occur in session. So the therapist might have toys available and coach parent on positive interactions, and then shift maybe to the parent really taking the lead there. And between appointments, the therapist would be encouraging practice of these skills at home, either on their own or with the supports of others. And this is very common in things like PCIT, which is parent-child interaction therapy, Triple P, the Positive Parenting Program, and Incredible Years program. And so I think some of us are very familiar with those. But what are some ways this approach could fail to work for all families, even though it's proven to work better in treatment as usual? So we start thinking about, parent-child stress, or that relationship is so negatively impacted by symptoms that they're having a hard time implementing it at home. Or just in general, the stress and parenting stress, the overwhelmed feelings that the parent has in regards to the child's behavior. Maybe the symptoms of ODD are so intense the child has a difficult time even making it to therapy. So we know that there are things that can get in the way of even evidence-based best practice outpatient services. And that's when you might start to look at a referral for CPST. So in that initial appointment, a licensed therapist or a licensed eligible therapist would start to explain the treatment plan, the basic approach. So again, you can see here, the approach doesn't change. We're still doing the same things that standard psychotherapy would be working at, but then a QMHP gets to come out to the home or other community settings and really make sure that what's talked about in therapy is reinforced at home, home or community, provide some direct coaching, support for those skills being learned. They can really do some support with the tangible things, sticker charts, tracking charts. Sometimes that can be really hard for parents to get started on their own, and just having someone there to really make sure some of those structure and practices are in place, and then they can actually practice it with the parent and the child. They also do some crisis planning, crisis prevention interventions and strategies, and practice those regularly to try to reduce any crisis that may have been occurring. And then look at the care coordination between multiple providers. That way, if you've been tracking behaviors and the youth is on medication for ADHD, but the family is concerned about the effectiveness, the CPST team can, help with that care coordination between providers to refer back to the medication manager, and just really make sure that the youth is getting the supports and services that they need to be most successful. In Tier 1, it may be 1 or 2 visits a week, and crisis can primarily be prevented through crisis planning and proactive skills. We start thinking more of a referral to Tier 2 if we know they're going to probably need more practice time, more interventions, maybe a behavioral health tech who really comes out and does that repetition and practice component. And there's been reports of crisis that probably are going to need crisis visits in person, and we'll still crisis plan, we'll still be proactive, but knowing that where they came in during that initial appointment might be indicative of higher levels of crisis needs. And then just remembering that all behaviors don't need to be tackled at once. It's a longer term treatment. Person-centered treatment planning will ensure the high priority behaviors and high priority behaviors to the youth and family, right? What's bringing them the most distress are addressed first, and then ongoing support and management is provided to maintain those skills. So in summary, for this first example, we know ADHD and ODD are common childhood conditions, but they can also vary in symptom presentation, impairment, and service intensity needs. And so evidence-based, medications, behavioral therapy approaches, combinations usually recommended, and many youth and families can successfully engage in that treatment. And that approach should be offered first, but there are going to be other families who need additional supports to learn the behavior therapy approaches, to stick with routines, to get the practice in, to make some of those modifications, behavior modifications. And so tier 1 is guided by the same model with the additional supports to provide more comprehensive service and supports. And tier 2 is going to offer all the same additional supports as tier 1, plus the repetition and practice of skills and supports at a higher intensity level. So those longer sessions, more times per week. Let's jump right into case example number 2. So if we have a 10-year-old with traumatic stress, again, evidence-based would say a cognitive behavioral approach or a family-based approach most likely to work. But look to refer to that CPST if you see the diagnosis with functional impairments and a need for more intensive or comprehensive services with real-world skill building, care coordination, and crisis supports. We don't change the model of change or the evidence, right? We're still going to be working on that cognitive behavioral approach or some family-based approach, but we want to make sure we're addressing it in the real world and providing them the supports they need to really walk that path of recovery from traumatic stress. So in a standard outpatient treatment, if you're looking at maybe like a trauma-focused CBT, you're looking at 12 to 15 appointments where psychoeducation is provided, skills are built, the trauma narrative is processed, there's a parent training component, there's some conjoint parent-child sessions. Again, practice occurs in session, but it's primarily didactic in nature. And between appointments, we really encourage youth to practice these skills at home with their caregiver support. So again, TFCBT, eye movement desensitization and reprocessing is another one, EMDR, and then in school setting, the cognitive behavioral intervention for trauma in schools. But sometimes that isn't effective or enough if the trauma symptoms are so intense that we start to see those impacts that we talked about when we talked about the tiers, like the community integration, social relationships are really not going well. They're having lots of crisis and are going to need a lot of crisis supports. That's when we might start to think about some additional supports and services are needed, and a referral to CPST would make sense for this young person. So same initial appointment, talk through the approach, the psychoeducation and youth skill building. QMHP comes to the home. So this might be one where that sample map guide where it talks about the trauma, the cognitive trauma, right? The QMHP might know that the LMHP introduced that to the family. So now they're going out and they're talking about that, or they're talking about relaxation or coping, and really helping reinforce the work that's driven by the evidence-based model. And the psychotherapy, the licensed eligible person can continue to direct the trauma processing through narrative or other work, but the QMHP can make sure there's a crisis plan, crisis prevention, that care coordination is happening between any providers involved. And again, when you're looking at between tier 1 and tier 2, really thinking about what's the intensity needed to support this young person. Are we looking at 1 to 2 visits a week? And prevention of crisis is really going to be done through planning and skill building? Or is this young person's traumatic stress symptoms so significant that longer visits, more frequent visits, more availability, and crisis intervention is going to be available to them, and that BHT, where can they come out and really try to support the in vivo exposures, any practice of skills that they are learning through the therapy process. So for traumatic stress, acute stress disorder, and post-traumatic stress disorder, we know they can have an impact on many youth, and there are evidence-based interventions for the symptoms that they might be experiencing. Many families can manage that with outpatient. Other families will need some additional support, and how we think about tier 1 and tier 2 is the level of need of support in the home. So the level of repetition, the level of practice, and the crisis management. Looking at a little bit older youth, now talking about a 14-year-old with depression and anxiety. Same as the last couple, right? Evidence would tell us that psychotherapy using a CBT, family systems, or interpersonal approach, really helpful. Medications such as SSRIs can also help manage symptoms. And we should be looking at CPST only if, in addition to the diagnosis and functional impairment, more comprehensive or intensive services are needed. And again, doesn't change the model of how we're going to approach it in the psychotherapy, but it just provides the supports to implement that at home or in other community settings as needed. So standard outpatient, 12 to 15 appointments, targeting relaxation, behavior activation, parent training, interpersonal approaches. Practice occurs in session, but primarily didactic. Between appointments, the youth practice these skills, caregivers support the youth, and CBT for depression, exposure therapy, and interpersonal psychotherapy are common approaches. But similar to the other couple, we know that sometimes there's going to be a little bit more needed than that. And if they're having crisis behaviors that need crisis response, if they're having a hard time with community integration because their depression is so intense, or personal care, they're not taking care of themselves, it's hard for them to get out of bed, get to school, all those things that we know can really impact a young person, then we might look at CPST. So licensed person maintains those evidence-based approaches, but we get the QMHP who can coach and support, use motivational interviewing to set behavior activation goals. We can do the additional skill building with crisis plans, crisis prevention plans, care coordination, and then tier 1 and tier 2 is still decided, just like in the other two examples, by the intensity of possible visits per week, what crisis level they're bringing in, what level of repetition with practice they might need, as we look to include a behavioral health tech if they're tier 2. So common, especially for teenagers, for depression and anxiety, ranging from mild to severe. So if you're on that more mild end, the effective medications and cognitive behavioral therapy or family-based approaches may be sufficient to address these symptoms. And there may be times if you're looking at the more moderate to severe ends where outpatient settings may be insufficient to support the youth and family to make the progress that they would like to see. So tier 1, you'd be guided by the same therapy model, but offering those additional supports. The care coordination, crisis support and planning, touching base in person or by phone, about 2 times a week, and tier 2 a little bit more frequently, longer sessions, more times per week, and you get that repetition of practice and skills.
All right, thank you so much for walking us through those examples. So just to summarize, we really appreciate you guys tuning in to listen to this webinar. The purpose is to give an overview of the draft policies for CPST youth that we had posted for informal public comment. We wanted to give some details, examples about the proposed service. You can find more information on our website. You can navigate there from the DMAS homepage, click on For Providers, and then Benefits and Services, Behavioral Health, and then you'll see our redesign page. And again, we welcome you to send in comments and thoughts on the model and the service definitions. And we really appreciate you taking the time to join us today. Thank you.
Thank you so much.
Thank you.
All right.